Good afternoon. The title of my presentation is Robotic Gastrectomies Offer Sound Oncologic Alternative for the Treatment of Early Gastric Cancers. Oh. Okay. Oh, sure. In most experienced centers in Korea, including Yonsei Severance Hospital, laparoscopy has become the preferred method of treatment for patients with early gastric cancer. This shift favoring minimally invasive surgery has prompted investigation into the role of robotic technology in the treatment of patients with early gastric cancer. But as we know, the evidence is very limited. We evaluated our experience at Yonsei for the last 6 years, comparing laparoscopic versus robotic gastrectomy. We can see on the bar graph here that we have increased the percent of operations performed minimally invasively, as shown by the red line. We retrospectively analyzed 591 patients who received laparoscopic resections and 236 patients who underwent robotic operations for their early gastric cancer from a prospective database. We compared the robotic group with the laparoscopic group for patient characteristics, as listed here, perioperative factors, including total operative time, length of stay, and oncologic parameters, including extensive exsection, lymph node dissection, and the number of nodes retrieved. As seen on this table, we found that we had a selection bias of younger patients in the robotic group, and the patients had a trend towards healthier patients in the robotic group, with hypertension being the most common comorbidity. There was no difference in gender or BMI between the two groups. As expected, we found that the robotic operations took on the average 49 minutes longer, as seen on this graph. Breaking down the robotic operation, we found that 20 minutes on the average was taken in the initial and docking periods. 142 minutes, majority of the case, was done with the surgeon at the console with the robot, and the rest with the assistant portion of the operation. 219 minutes, while it takes longer than the laparoscopic operation, is actually acceptable and consistent with published data from reports of laparoscopic operations for early gastric cancer. We also found that the blood loss was very little, with estimated intraoperative blood loss being 148 cc's for the laparoscopic group and 92 cc's for the robotic group. We also found that there were no difference in the two groups in postoperative complications, with a total of 13.7% in the laparoscopic group and 11% in the robotic operations. This is consistent with published data for laparoscopic operations for early gastric cancer, ranging from 2.5 to 25%. We found that the length of stay, we were surprised that the robotic operations, the patient stayed 3/4 of a day longer. We believe that this is skewed by a couple of patients who ended up staying in the robotic group for a complication, one for mortality at 170 days and another at 203 days in the rehab after a complication after a bleed. Taking out patients who had complications and analyzing just those patients who followed the non-complicated post-op course, we found that the laparoscopic group had a half day longer in the hospital. This is supported by the median length of stay following Yonsei's clinical pathway. Post-op day 5 was seen. Most patients, 61% of the patients in the robotic group were discharged on post-op day 5 compared to 48.8% in the laparoscopic group. And finally, in terms of oncologic factors, we found that there was no difference in the extent of lymph node dissection or the number of lymph nodes retrieved. As you can see in the bar, D1A dissection was done in minimal amount of patients, and D1 beta and D2 lymph node dissections were the most common, and in each group there were adequate number of lymph nodes retrieved for both groups. And all the tumor margins were negative. So in summary, robotic approach to early gastric cancer achieves R0 resection with adequate lymph node dissection. While taking longer than the laparoscopic resections, it's acceptable range of operative time. We also found less operative blood loss, which is statistically significant, but clinically, I don't think there's much difference. And we found that there is no increase in postoperative complications for the robotic gastrectomies. And it's possible that they may provide advantages of early discharge from the hospital. So where do we go from here? Robot-assisted approach to earlier stage gastric cancer is a promising alternative to laparoscopic surgery in experienced centers. Judicious investigation of robotic technology in the treatment of gastric cancer is warranted. However, translating the perceived advantages of robotic technology into clinical benefit for the patients is still pending outcome, awaiting tumor recurrence and long-term survival and cost-benefit analysis. Thank you for the opportunity to present at the World Endoscopic 2010, and I'm open to questions.
Thank you very much, Dr. Woo. Questions?